Hey everyone, welcome to this rapid-fire masterclass explainer designed to help you think, act, and troubleshoot exactly like a seasoned vascular access specialist. If you're prepping for the VABC exam, you already know that this field is way more than just sticking a catheter into a vein. It's about sharp clinical reasoning, deep empathy, a rigorous grasp of the evidence, and strict ethical standards. Today, we're diving headfirst into a comprehensive study guide. Consider this your robust front row lecture. We are going to cover it all, beginning to end, so you can confidently ace this exam and actually elevate the standard of care you provide every single day. Let's jump right in. Here's the game plan for today. We're mapping our syllabus exactly to the 4 official domains of the exam blueprint. The VABC exam blueprint: Domain I, clinical knowledge; Domain 2, patient communication; Domain 3, evidence-based practice; and Domain 4, legal and ethical. All right, let's start with the VABC exam blueprint and understand the syllabus. This is your very first strategic step to passing. Take a look at how they actually weight this exam. A massive 65% of your score depends directly on clinical knowledge and application. And honestly, that makes total sense, right? You absolutely have to know your devices, your anatomy, and how to manage complications. But please do not sleep on domains 2, 3, and 4. Together, they make up that remaining 35%. And frankly, those domains are what elevate you from just being a skilled technician to becoming a true holistic vascular access specialist. Moving right into Domain I, clinical knowledge. This is the hands-on foundation, the absolute meat and potatoes of the exam where your technical skills truly save lines and save lives. Listen, if you remember one number today, make it 33%. Your catheter-to-vein ratio literally has to be 33% or less to drastically slash the risk of thrombosis. To put that into perspective, if you're looking at a vein that's 4 millimeters in diameter on your ultrasound, your catheter shouldn't be any more than about 1.3 millimeters. This calculation isn't just a suggestion, it's a massive safety standard, and you'll definitely see it on the exam. And that perfectly tees up device selection. You wouldn't use a hammer for a screw, right? Always match the device to the therapy. For example, vesicants absolutely demand central access because the high blood flow in those central veins is necessary to dilute those harsh medications. You also have to assess the vein itself. A healthy vein is compressible on ultrasound, and your sweet spot for depth is between 0.3 and 1.5 centimeters. Any shallower, and you risk a through-and-through puncture. Any deeper, and seeing that needle tip becomes incredibly tough. Oh, and here's a golden rule for your renal patients. Avoid PICCs in chronic kidney disease stages 3 to 5. You have to protect those upper extremity veins for future fistulas. Okay, so the line is in, but where exactly is the tip? Confirming proper tip position is completely non-negotiable. Whether you're using ECG guidance, watching for that sharp peaked P wave as the tip approaches the heart, or you're checking a chest x-ray, you must confirm the tip is resting at the lower superior vena cava or the cavo-atrial junction. That is the absolute standard before you push anything through that line. Because a malpositioned tip, that's a one-way ticket to severe complications like arrhythmias or serious vessel damage. Speaking of complications, the exam is going to push you hard on your ability to recognize adverse events. What if you get an inadvertent lung puncture during an insertion attempt? You have to know how to grab that ultrasound and assess the damage. You're looking for the pleural line. You're checking for lung sliding. Spotting a B line or comet tail artifact is how you evaluate the risk and presence of a pneumothorax. Quick, decisive recognition right here is absolutely vital. So, what happens when a line simply goes down? It won't flush, it won't draw blood. You can't just guess. You have to follow a standardized analytical response. First things first, figure out the type of occlusion. Is it mechanical, like a closed clamp or a kinked line? Is it chemical, from a precipitate caused by incompatible meds? Or is it thrombotic, like a fibrin sheath or an intraluminal clot? Your next move depends entirely on this diagnosis. Always clear out any mechanical issues first, and if you are dealing with a thrombotic occlusion, administering a thrombolytic like alteplase is your key evidence-based fix. All right, let's shift gears to Domain 2, patient communication, transitioning from the vein to the actual human being attached to it. I really want to stress this. Communication isn't just some fluffy soft skill. It is a vital clinical intervention. Adjusting your language for health literacy is a huge part of patient safety. You've got to drop the scary, complex medical jargon. Imagine walking in and telling a patient with zero medical background that you're placing a central venous catheter. That's terrifying. Instead, use clear, highly descriptive language they can instantly visualize. Say something like, "We're placing a long IV that ends near your heart." Keep it simple. And if you absolutely must use a medical term, define it for them right then and there. And when you step into an anxious patient's room, always start with the why. Don't just walk in and announce a procedure. Frame the placement of the line as a safe, necessary solution. Try saying, your care team wants to give you medications that are too strong for the small veins in your hand. Boom. Now they understand this larger line is actually there to protect them. You're pairing the benefits with the risks, and you're building trust from the very first second. Teaching doesn't stop once you've explained it. You need to genuinely empower your patients. Use the teach-back method. Ask them to explain the device back to you in their own words. Remember, this is testing your teaching, not their intelligence. Always hand them a one-page written instruction sheet because studies actually show patients forget like 40 to 80% of verbal instructions within minutes. No way around it. Also, if they're non-English speakers, you must use certified interpreters. Never use family members. You need absolute neutrality. Finally, when you're collaborating with your own clinical team, rely on structured tools like ESBAR, situation, background, assessment, and recommendation to escalate issues clearly and rapidly. Onward to Domain 3, evidence-based practice. This is the true science of access. Let's look at the research that keeps our practices standard and safe. As a true specialist, you have to know how to appraise research. Now, expert opinion is a great starting point, sure, but you need to understand the hierarchy of evidence. Randomized controlled trials are fantastic, but systematic reviews and meta-analyses, they sit at the very top of the pyramid. Why? Because they synthesize a bunch of studies to give us the most reliable true effect size. Knowing how to spot bias and actively apply these top-tier findings to your own unit is exactly the kind of competency this exam is looking for. So how does all that top-tier research actually reach us on the floor? Through major guidelines. The exam will heavily test your knowledge of these big organizations. You've got to know that INS provides our overarching standards of practice, everything from flushing protocols to that 33% catheter-to-vein ratio we talked about. The MAGIC guidelines? That's your absolute gold standard for device selection. KDOIKey dictates dialysis access and vein preservation, and SHEA focuses intensely on infection prevention and CLABSI bundles. Evidence-based practice is basically a three-legged stool. You need the best evidence, your clinical expertise, and the patient's values all working together. And finally, we hit Domain IV, legal and ethical. These frameworks are the ultimate shield for both your patients and your own professional longevity. Let's unpack this definition because honestly, it is the bedrock of medical law. Every single action you take is measured against the standard of care. Basically, what would a reasonably prudent clinician do under similar circumstances? This standard isn't just someone guessing. It is rigidly defined by those national guidelines we just covered, your state board practice acts, your hospital policies, and crucially, the manufacturer's instructions for use, or IFUs. Now, if you step outside that standard of care, you're wandering into malpractice territory. To truly understand your legal liability, you need to know the 4 specific elements required to prove negligence. First, you must actually have a duty to the patient. Second, there has to be a breach of that duty, a failure to meet the standard of care. Third, the patient must suffer actual harm. And fourth, there has to be causation, meaning your specific breach directly caused that harm. You need all 4. So how do you protect yourself and respect your patient's autonomy at the exact same time? Proper informed consent. And listen, consent is a comprehensive educational process, not just a rushed scribble on a piece of paper. It requires assessing the patient's capacity and fully disclosing the why, the risks, the benefits, and the alternatives. You have to ensure they truly grasp what's happening and are authorizing the procedure voluntarily. The only real exception here is in a true, absolute emergency where a delay would cause immediate harm. That's where implied consent takes over. But how do you actually prove all of this happened in a court of law? 2 words: meticulous documentation. Thorough documentation of the consent, the clinical indication, the technique you used, and the patient education you provided. That is your legal shield. On top of that, running a strict timeout verification before any invasive procedure ensures you have the right patient, the right site, and the signed consent verified. Yes, efficiency is great, but never ever at the expense of these ethical and legal safety stops. So as we bring this explainer to a close, ask yourself this: are you ready to step beyond the exam? Mastering these 4 domains, your clinical skills, how you communicate, the evidence-based practice you apply, and the legal frameworks you operate within, it isn't just about passing a multiple-choice test. It is about becoming a dedicated, top-tier specialist who literally safeguards every patient's lifeline. When you walk into that exam room, trust your prep. Rely on the evidence and remember the massive impact you have on patient outcomes every single day.
Keep studying, keep preserving those vessels, and thank you so much for joining me today.